host a panel of speakers. We'll go over the logistics for today's talks at the beginning here, and then for the first few minutes, and then we'll go ahead and get started right at 11:05 with our first speaker. Maybe just to start, by way of introduction, just to introduce myself and Dr. Sheth as the co-chairs for today's program. My name is Nirmish Singla. I'm a urologic oncologist at Johns Hopkins, and happy to be a scientific co-chair with Dr. Sheth. And Dr. Sheth, if you want to introduce yourself.
Thanks, Nirmish. My name is Kun Sheth. I'm a pediatric urologist practicing at Stanford and have been with the IAUA since I guess last 5-6 years now. And we are excited to bring you this webinar. I think we had a webinar early during pandemic, and so this is a exciting opportunity to do it again and see. It seems like we've already gotten a lot of interest. And I'll let Nirmish talk some more about the program.
Sure. Yeah, and we're going to, of course, have a larger scientific program at the annual AUA meeting in April this year in Las Vegas. So that'll be an opportunity to have an in-person platform that will be able to develop a program. And anyone who's interested, certainly in contributing to the program, are more than welcome to reach out to Dr. Sheth and myself, since we're just now in the process of putting the agenda together for that. Just some quick logistics. So for the plans for today's talks, we've planned it such that there will be roughly about a 15 minutes talk from each presenter, followed by a 5-minute Q&A buffer afterwards. Just to keep things, because of how many people are expected to join, it may be best to present your questions in the chat, and then Dr. Sheth and I will sort of moderate the Q&A section. Or you can also maybe raise your hand, and we'll try to sort of approach the system, the question and answers more systematically. And then we will have a 15-minute panel discussion at the end. So just in the interest of keeping things on time, we'll try to sort of stick to the agenda that you see on the screen. And then if we need to do some spillover of questions, for example, for any of the speakers, we will push them to the panelists, and Dr. Sheth and I will keep track of any questions that remained unanswered. But we're really looking forward to a very engaging discussion, and just out of respect for the speakers, we will ask, unless the speakers suggest otherwise, maybe hold your questions until the Q&A portions, and that will sort of help with the flow of everything. Dr. Sheth, was there anything else that we needed to discuss logistically?
Not logistically. I just wanted to say that we wanted to focus this talk on AI in urology because we know that there's been a lot of changes in the last few years, and it's figuring out how to incorporate it into our field. The sooner we learn how to do it, the more we can keep with the times. And so this was kind of an opportunity to get a gauge into that realm.
Absolutely, and we try to make it kind of a broad sweeping, as you can sort of see from the agenda, some of the different arenas in which AI may be playing an increasing role both today and in the future. So hopefully this will give a snapshot as to what the future may hold in this space. So on that front, I'd like to introduce our first speaker. And Dr. Kavousi, please feel free to start sharing your slides if you'd like. Our first speaker is Dr. Nicholas Kavousi. Dr. Kavousi is a minimally invasive surgeon specializing in the application of novel technologies in the treatment of urologic diseases. He works at Vanderbilt University as an assistant professor. He's a member of the Vanderbilt Institute of Surgery and Engineering and is actively involved in multiple research projects furthering the integration of technology and surgery. And the title of his talk is on improving endoscopic kidney stone surgery using computer vision tools. Dr. Kavousi, take it away.
Thank you. And I want to thank Dr. Singla and Sheth for putting this together and inviting me. I'm always excited to sort of talk about our work. And to reiterate what I think what Dr. Sheth said, these AR tools are coming, but I still think they're very, very early in their development. And it's really up to us to shepherd these in and understand their applications, their utility, and validate them. So a lot of what I'm going to speak about is really interesting to me, but these are really preliminary models. And Whether or not they're ready for game time, that's another discussion. But I'm going to speak about some of our work that I do want to disclose that a lot of this work is NIH funded. So the motivation here is the ongoing increase in stone incidence that we're all familiar with, and that leads to an increase in stone events, increased number of interventions, and increased of system burden. Additionally, when we operate on these people, we know it's important to get these people stone-free. Stone-free rate is actually pretty low, though. And most patients will need a repeat surgery within the first few years after the index surgery, though endoscopic stone clearance predicts recurrent stone events. So we know if we are happy endoscopically, then the patients will be happy. We don't really know what happy endoscopically really is, though. There's lots of different definitions of stone dust, and most people do dust rather than fragment. And we don't really know how stone dust associates with fragmentation, though Keller and his co-authors looked at different types of stone dust to define this in a benchtop model. There's really no association with clinical outcomes. And these are sort of things that we've started to consider in our lab to try to figure out how we can best use these tools to improve surgery for our patients. Now, computer vision is a subset of artificial intelligence that uses visual data and analyzes visual data to associate with some sort of outcome. And we see this in augmented reality. We know this about self-driving vehicles. When we sign into our phone using face recognition, it's these sorts of technologies, and we're applying them in endoscopic surgery. And we hypothesize by using these models, we can improve identification and tracking of stone. We can have better metrics to evaluate experience, surgical experience, and hopefully be able to take endoscopic scenes, objectively evaluate them, and associate them with outcomes. To start all this, we've taught a computer what endoscopic surgery looks like. We took 136 videos of endoscopy for stone, and we broke these videos up into over 20,000 frames. We went through the frames one by one and annotated, meaning labeled the frames to identify stone, to identify normal tissue. It was tedious work, but it had to be done. And we did this to actually teach the computer what endoscopic surgery looks like. And we used subsets of the frames to validate, that is, build and improve upon the model while we were training it, and test it. And we used a bunch of different metrics to look at it. And this is what we came up with, where we actually have a computer vision model that can identify and look at stones and track stones in real time, with left being the raw output, the middle panel being the model prediction, and a heat map on the right of each pixel's probability of being a stone. And we looked at the performance in this model, both in fiber optic and digital scopes. And we also looked at the different surgical subtasks, because we know that during stone surgery, there's lots of different things that happen, and there's different parts of the case that probably require different considerations of the model as we go through it. So we looked at stone localization, stone fragmentation, and evaluation of residual fragments, that is stone dust at the end. And the main outcome we looked at was this DICE score, which is an industry standard in computer vision that looks at overlap, the overlay between the model prediction and what we're actually seeing. And we compared that to benchmark it against board-certified urologists. Does our model compare as well as urologists? And we found that both from the ureteroscope type and based on surgical task, the model performs fairly well and fairly consistently. You can see here, this is lasering down here, and how the model performs during active lasering, and then fragmentation of stones. And we look at different laser settings and whatnot. In comparison against experts, our model over here on the right pretty much performs similarly to expert endourologic surgeons as well. So our model seems to work as well as an expert surgeon. So this gives us a way of real-time objective measurement of endoscopic surgery for kidney stone disease during localization and treatment. Again, we can do it in real time. And the exciting thing about this is that we now have different ways of evaluating the surgery scene objectively. And let me give you an example of that. So we sought to use our technology to see if we could distinguish between surgical experience during endoscopic stone surgery. So we took 46 surgical videos from 9 surgeons, 3 of whom were experts and 6 were residents. Based on this sort of categorization, less or more than 100 urologies per year. And we used our model to see if we could find some metrics that would actually differentiate the experts from the trainees. And we looked at this both for stone localization and laser stone ablation. And the metrics we looked at specifically were loss of stone visibility. How often did the surgeon lose track of the stone while operating? The screen occupancy of stone, how close really was the surgeon to the stone? How much of the screen did it take up while they were treating? And the frame-to-frame change in stone occupancy, how much wobble was there during treatment? These are things that we see as we train residents that know that that as they develop and grow in their skills, these things kind of become more refined. And these seemed like metrics that we could potentially differentiate trainees and experts. And we did find differences in these metrics. And what we look at here is on the y-axis, this is the percentage of the frame occupied by stone. And on the x-axis is time. The red is a trainee, the blue is the expert. You can see that the trainees overall had a lot more instability in terms of holding the scope, or was all over the place. They lost track of the stone more. And during the localization task, they tended to be closer than experts in finding these stones, which I think sort of refers to the development of sort of the motor coordination during endoscopy that we see. So, like I said, these are preliminary sort of models, but we do think there's some signal here that could suggest that these tools could be used to better evaluate trainees for competency. The other thing that, as I mentioned before, is that a lot of what we do in surgery is gestalt. We wanted to see if we could use our models to better understand what good dust is, so that we could teach trainees and also ourselves in terms of how we know a patient's going to do post-operatively based on what we're seeing endoscopically. And to do this, we took 70 videos of stone dust after ablation. And we broke those up into over 30,000 frames. 32 of those videos showed patients that were stone-free classified based on post-operative imaging, which was mainly CT scans, and 38 were not stone-free, which was any residual fragment. And we trained the model with 80% of these frames using our segmentation software as an auxiliary input. So this was a new model that we used the segmentation software to build up and use as a reference, so that the computer already knew what stone surgery looked like and was able to sort of take that next step to say, okay, we know what surgery looks like. What is this really? How do we fine tune and look at this dust to predict outcome? And there was really no difference based on the stone composition, location of the stone, and whether or not patients were stented preoperatively. And we saw that based on individual frames, the model had fair accuracy and could actually predict, based on appearance of dust per frame, if a patient would end up with a residual fragment. And if you looked at videos, took the frames sequentially across videos, it accurately predicted about 80% of videos to predict whether or not a patient would have a residual fragment. And here's a confusion matrix showing this. You see this fine dust up here of a patient who was indeed stone-free as predicted by the model. A patient down here with larger, chunkier fragments that had residual stone on imaging at 6 weeks, which the model also predicted. And the question is sort of, what about these sort of the false positive and false negatives? What's going on there? And we don't have a great understanding, because one of the issues with these technologies is they're black box, and we don't really have a way of predicting explanation of how these networks work. And there's lots of different things they may be using, different textures, edges, colors, patterns within the frame to make these conclusions, but it's difficult to really understand. So that's something we're working on. You can set different filters and look at these frames to understand really what the model's doing to help improve outcomes going forward, which is what we're working on. The other issue is that this is relatively small numbers, and this is a single institution. And these AI models that you're hearing about today are all notoriously prone to overfitting. So we really need to look at external validation, which we're doing currently, and also understand sort of more the impact of perioperative factors, different laser types and settings, and really the clinical significance. As mentioned, these all patients were those that had imaging at 6 weeks afterwards with a residual fragment. It's unclear what happened to them after that, or a year if they needed recurrent surgeries. And that's really, I think, what's important. Who cares if they have a little bit of dust behind, but if it becomes a problem for them, then we'd want to know. So as I mentioned, we're working on robustifying our database and validation, and given a lot of the guardrails in terms of sharing within data between institutions, we're committed to making a lot of our software open source so that other institutions can use and validate it. And as I mentioned, sort of figuring out the clinical implications of this work. And lastly, I do want to talk about our work towards endoscopic navigation, because seeing right in front of you and having a model that can analyze the scene right in front of you is one thing, but having a model that can analyze an entire three-dimensional structure of the intrarenal collecting system as you operate, I think will give us a lot more information and be able to help guide and build tools to make us better surgeons in the operating room. And this is an example of what we're doing here. In this project, what we started to do is use preoperative CT scans to actually segment and remove three-dimensional meshes, models from these, and then use the endoscopic video to develop a three-dimensional point cloud, bring them together, register them, and then allow us to know where we are in space during surgery. We're doing this both in phantoms and real patients, and an example of this here, if this will run. This is, on the left is the endoscopic surgical scene that we're getting with the digital ureteroscope. And on the right is a three-dimensional map we're building based on that endoscopic scene, with the red diamonds here being the scope tip. So we can understand where the scope is within the renal collecting system as we build this three-dimensional map. We can then take that map, and this is in a phantom, we do the same thing, and then register it. That means match it up with the model we get from a preoperative imaging. So on the left, we have the image from a kidney phantom. In the middle, we have a three-dimensional mesh of that phantom, and the right is a depth plane. And you can actually see that this can actually line up such that we know where the scope is within the kidney, within the CT scan contextually, to understand where we are. We've looked at accuracy of how well the system looks, and we're actually at less than 2 millimeter accuracy in patients. So this is technology that we're really excited about building on, and hopefully using to better understand navigation, where we are endoscopically, and improve outcomes for patients. I want to acknowledge the large team we have at the Vanderbilt Institute of Surgery of Engineering. And again, I appreciate the opportunity to talk this morning, and I'm happy to answer any questions.
Thanks, Dr. Kavusi. That was really a wonderful talk, and right on time too. So I think we have 5 minutes for some questions. If there are any from the audience, feel free to raise your hand, or it's not a huge group. You're welcome to, of course, unmute yourself.
I think we are too ignorant about the whole thing, so I don't have any questions, but it's very impressive presentation.
Thank you so much.
I have a question, Dr. Kavusi. That was a great presentation. It seemed very stone specific. So how do you think some of these things can translate to other areas of medicine, or urology even specifically?
Yeah, that's a great question. So you may have noticed some of those videos were actually not stones, but also upper tract tumors. So that's sort of where I am in those areas, because there's a lot of overlap there. The kidney is a nice organ to start with because of the collecting system, MFW, the branching. There are specific points you can actually see and use to help understand where you are in space. If you look at the papers that are doing it in bladder is a lot harder because it's so round. that it's easier for the models to get lost. There's less specific points and corners for it to really sort of to register to, though some people are doing it and there's ways to do it. And the other thing you need to consider in the bladder, or if you're looking at other organ systems, ENT, pulmonary, GI, is tissue deformation. And the kidney has some deformation, not as much as other systems, but it does. And that's going to impact how these models play out, I think, in other, for other applications in different organ systems. If that answers your question.
Yes, thank you.
I had a question. As you've kind of talked about the stone-free rates and measuring how, like, what's going to predict, have you considered kind of testing new technologies? As I know there's a lot of incoming technologies for stone fragment removal, things like that. Like this, I wonder if this is a way to expedite testing for these technologies as they're trying to evaluate their efficacy, going to the FDA, things like that. Has that been something you've thought about?
Yeah, I think it's a good point. I think we're so early that that we're just trying to make sure this works and is reliable and validate and all that. But I think to use this as a tool to understand how these different lasers maybe dust as well, how the suction sheaths, how small these fragments need to be. So there we've had some preliminary discussions based on that, but I don't think we're quite ready to actually evaluate these things, but it'd be great to get there one day.
Yeah, just because I think it would decrease so much of like time that is required for testing, right? When you can have automated models doing it.
I've had the pleasure of being able to collaborate with you on some of your UTUC models. And as you know, in the upper tract, capacity for both visualization and manipulation is often more limited compared to, for example, the lower urinary tract. Do you foresee this as a way that would be translatable to enhanced visualization techniques, similar to like NBI or blue light in the bladder? And in what ways would you see this either being sort of either automated or semi-autonomous for other similar applications, whether stones or UTUC tumors within the upper tract, when thinking about like a commercialization strategy and what that would look like for the general community?
Yeah, no, it's a great question. And I'm gonna again say what I've said, I think, a few times, is we don't know. The short of it is that based on what we understand, what we're seeing is that, for example, in the tumor realm or whatnot, the models seem to do at this point as well as experts. Right. So if you have someone who's really experienced and can look at a tumor and say, this is going to be a high-grade thing, this is what we should do, this is a high-risk patient, that sort of stuff, that's helpful. But most of people in the community are not experts, right? They are trained to do everything. They do everything. They may not see as much upper tract or stones as a tertiary care center or something like that. So things like how we can integrate this to help those surgeons improve decision making is one thing. And then how can we integrate things like NBI or blue light or something like that down the line to actually improve these models and maybe actually teach them to see more than what surgeons can see at this point? That we don't know yet, but I think it's an exciting thing to try to incorporate some of this stuff going forward.
Great. Well, Dr. Kabusi, thank you so much for the presentation.
Thank you guys for having me. I appreciate it.
Definitely. I think we can move forward with our second presentation, and it's my pleasure to announce Dr. Raveen Sayan. She's a fellowship-trained female urology and assistant professor at the University of Miami, and a key member. She's now secretary of the IAUA. So very excited to have her talk today about the role of AI in surgical counseling.
Thank you. Thank you for the introduction. I'm just going to share my screen. So this is a little bit of a different talk from the last one. I'm kind of moving more to the clinic base of how AI can help us just feel happier, more effective, and keep patients happier. So just as a little bit of an introduction, sorry. So what I'm going to start with first is I'm just going to, draw attention to what are some of the challenges we face in medicine right now between patient and provider communication. And really, what is the role? How can we incorporate artificial intelligence in our clinical practice and surgical counseling? What have we learned so far? And really, what are the next steps? What are other opportunities we can explore? Let me take a minute, just kind of, outlining the things that we all know. What are the challenges that, both the patient and the provider face when it comes to communication? So as we know, there's been many studies and there's a lot known on what makes a patient unhappy. So one of the top things that patients will describe is they feel like there's poor communication with their surgical team. It's the most often reported cause of dissatisfaction. And most commonly, patients report saying that they didn't get enough counseling on their treatment or their disease disease and their treatment options. Sorry, I'm just setting a timer so I don't go over. And the second thing they also comment a lot about is they don't feel like they spent enough time with providers. They often, especially when it comes to surgeons, they feel like the surgeon has one foot in and out of the door. Their concerns aren't being adequately addressed. They talk about problems with accessing providers. They have long wait times. When they have questions, they can't get a hold of them. And, in terms of surgery, as I mentioned, they talk about how they didn't understand the success rates, the failure rates, the complications. And so it can result in major disappointment, which ultimately leads to dissatisfaction. In other areas is there can be a perceived lack of empathy. They feel like they're not getting appropriate follow-up. They're feeling unheard in visits. So how can we improve patient satisfaction? And we all know that this is a big focus, especially in our academic centers, the strong focus on Press Ganey scores. So whether, we like it or not, this is a large part of what we have to spend time thinking about and working on. So ways to improve their satisfaction is spend more time with them. That seems pretty straightforward. Increase the length of consultations, greater use of secure messaging platforms with, rapid responses. Well, obviously the downside of this is physician burnout. And we also know that physician burnout is very high. And especially these days, as a lot of us surgeons have these challenging metrics, trying to see a lot of patients in clinic, trying to get a lot of surgeries done. You can't have it both ways. And so, the major reported areas physicians describe of feeling burnt out is they have an increased workload, the long hours, high volume of patients, the emotional strain. We all have experienced compassion fatigue, the emotional taxing nature of especially surgery, but really any medical field. The administrative burden. So yes, make patients happy by sitting on secure messaging all day. Well, that's really hard on the physician and is a major cause of burnout. It leads to work-life imbalance. And finally, patient complaints are exhausting and it definitely affects your morale. So what can we do? There's really a real gap here where we need to find a way to improve patient satisfaction without resulting in physician burnout. How can we balance the needs of both the patient and the provider? I am not providing this solution. I am providing an area where we can try and get to a better equilibrium. So I want to introduce the concept of using AI when it comes to surgical counseling and what have we learned thus far about how we can utilize AI. I want to just point out this one paper that got a lot of press and attention. This was referenced in the Daily Mail, which is a large online newsletter, a newspaper source, study out of UC San Diego. So basically what they did is they had patient questions that physicians answered and then ChatGPT answered. Then 3 doctors were blinded to whether the response came from a doctor versus the ChatGPT. And doctors then rated how empathetic the responses are, were they high quality responses, and when it comes to which response would you prefer to the same question, which would you select? What they showed is doctors themselves acknowledged that majority of empathetic responses, were higher in the ChatGPT group. There was a real lack of what they perceived to be empathetic responses. The quality was like much greater, 80% versus 20%. And super interestingly, doctors themselves preferred the responses by the ChatGPT. They felt like they did a better job of managing patient expectations and patients feeling heard. And again, this just kind of outlines it that the responses, when they graded it from very poor to very good, ChatGPT outperformed physicians' responses, and the same was, how well they answered and how empathetic the answers were. So we decided to address this. Okay, so we know that doctors think ChatGPT can do a good job. Well, what do patients think? So this is really the crux of our study that we performed. We hypothesize that patients themselves will appreciate the opportunity for additional time spent with an AI bot who can answer their questions. So we utilized an AI chatbot to help counsel patients. What we did is we recruited 51, and we had to use English-speaking patients because at the time there was no translated chatbots, and I believe there still is not, although I could be wrong. But at the moment we had to restrict to English because at the time we had to restrict to English just because it was pretty nascent in the ChatGPT function. So 51 patients were recruited from an outpatient urology academic clinic. This is what the flow looked like. So first, a patient presented to clinic, met with the urologist, was given a diagnosis, treatment options, counseled in the standard of care way that we counsel patients. Any questions that the patient had at that time were answered. So standard of care conversations. Then patients were offered to be enrolled in our study just to spend a little more time with the chatbot and ask any additional questions or the same questions if they didn't have additional questions. So then patients were taken into a room with a research team member, and with the physician not there, they asked whatever questions they had, and they would ask things, a whole range of things, either about their new diagnosis, their treatment options. Some of them were even asking questions about like hypertension, things unrelated to the visit. We then asked the patients to complete a satisfaction score about how they liked the counseling from the surgeon versus the AI chatbot, and what were their preferences regarding the two. We used Likert measures to obtain satisfaction scores. And then the surgeon reviewed each of the AI chatbot responses later, so not in the presence of the patient, reviewed the transcript and rated the accuracy of the information provided. This is what we found. So of the people was majority women, which makes sense. It was my clinic, so it was mostly women, although there were 8 males. And what's interesting is women were much more likely to prefer the physician over the AI. Men were more likely to be kind of equivalent. Age didn't have a clear relationship, although it did seem that the older people, which is logical, people tend to be less familiar with technology as they age, did prefer physician over the AI bot, but it wasn't dramatic differences across age groups. Non-Hispanics favored physicians, and there wasn't a clear relationship when it came to race or ethnicity. But we see that, Blacks and others were more likely to report preference with physician. And when we looked at the indication, again, it was a urogynecology clinic. So we divided it by overactive bladder and urinary incontinence. We found that the non-OAB urinary incontinence indications, so this usually means the more complex neurologic patients, they preferred the physician pretty dramatically more, which makes sense. These probably were more complex conditions that perhaps there was a limitation in terms of the AI chatbot responses or patient comfortability. And these are some of the questions. So is a single operation the same as a bladder operation? I'm taking Ozempic. How will this interfere? What is the urethroskopy? Are there any bad exercises? And these are questions that, they're probably questions patients don't think or don't really want to ask. They're pretty basic questions or things that aren't really related to, the more complex thing. And so I think it's really interesting that these are the questions they asked, the things that it was almost like they didn't want to ask the surgeon, me, but they wanted to ask the chatbot to better understand things. So then when we reviewed it, we found that AI did a very good job of understanding and responding. In terms of accuracy, there were some gaps, and I'll get into that. Did it meet the standard of care, like how we felt was appropriate counseling and a standard of care assessment? Majority, yes, although there were some gaps. And this is really where this drove some of the lower scores, is there was some important information that was incorrect. And so when we looked at that, these are the key gaps that we noted. There was some gaps in when it came to hematuria guidance and guidelines. It was a little inarticulate about the difference between gross and micro, and was in some cases over counseling things like cytology. So there was room to improve AI there. Some of the UTI treatments were a little outdated or inaccurate, at least by the way we follow AUA guidelines. One of the key things was, I did this study last year, and the newer battery related to sacral nerve stimulator have much greater longevity than they used to have, but the AI chatbot was relying on the old information. So they were giving longevity results based on the older models of the battery. So that was, that's a major gap, obviously, when it comes to counseling. So what are the take-home messages? Majority of patients do prefer the physician, but nobody did not appreciate the opportunity to ask more questions of the chatbot when the visit ended. The AI was mostly accurate, which is great. There were key contemporary updates in relation to like guidelines of treatments and treatment success rates and complications. There was some gaps there. I think it's important though to remember that AI is a learning tool. So there's an opportunity to develop a chatbot that you tailor to your practice. You can teach it updates. If you do these checks, you can help teach the AI, no, these are the new battery device durabilities and longevities, et cetera. So I think it really is an interesting tool that can be used. And then, there's so much more we can do. This is just one idea. So the reality of AI is the sky is absolutely the limit. And the limit that actually happens is our imagination. If you can imagine it, AI can help you create it. So you got to think outside the box. So another tool that we've been exploring is something called Notebook LM. So the way it acts is you upload a source. So some sort of file of information. You can use slides, YouTube, Google Docs, PDFs, whatever you need. It gathers all the data, identifies key insights, and then it generates like a podcast so that it's as if you're listening to a podcast. So what we did was just to test the function, we took the AUA core curriculum looking at interstitial cystitis, bladder pain syndrome, and we inputted the link. So that's the direct link to the core curriculum. We gave no additional inputs. And I'm just going to let this play. It's truncated. It was a 20-minute podcast. I won't make you listen to that. But I just thought there were some key interesting things. And I just want you to hear the tone of how it's so collegial and interesting. I'm going to press play now.
Sorry, is anybody else able to hear that?
No, we couldn't hear Raveen.
Oh, I'm so sorry. I thought it was playing. Okay.
Audio.
Okay. Now I don't know how to do that. So then let me just, how do I share audio? Do you know how to do that, Kunj?
Yeah, it's something, it's in your audio settings.
Oh my goodness. Let me see if I can do it quickly. If not, I'll just as I'm trying to do this, basically it's like two voices talking. It sounds like they're friends, and it is.
If you would like to you need to stop sharing your screen, share it again, and click share sound when you share your screen.
Okay, got it. Thank you.
No problem.
Oh my goodness. Wow. Thank you. Learning. 1 second. Okay. Back on track. All right, tell me if you hear this. It just needs a moment.
All right, so let's get into this deep dive about interstitial cystitis or bladder pain syndrome, ICBPS. We got some excerpts here from the American Urological Association Sounds like we're trying to understand this condition better. Impacts millions. Still a lot we don't know about it. We're going to break down
Fast
the
forward a
essentials
bit
from the.
since we're a
It's not
little.
just a diagnostic tool. It's crucial for guiding treatment
They're
decisions.
talking about
Yeah.
cystoscopy
What happens if they
fulgurations.
do find honey lesions during a cystoscopy?
Well, the AUA guidelines recommend a procedure called fulguration, which basically destroys the lesion. They might also inject a steroid called triamcinolone.
You get the point, but it's such an interesting way to make information that's complex accessible. And this took 2 minutes. You just input the link, and then again, you can edit it. You can modify it to tailor it to the things you want to emphasize or remove, shorten it. So it's just fascinating how easy things can become if we get more facile with utilizing AI.
All right, so let's get into the.
I'm going to skip. So I just wanted to share this, even for this presentation, when I was coming up with, okay, what are the patient dissatisfactions? I was sitting on PubMed, I was doing all the research, and I was like, wait a minute, this is an AI talk. So let me see how I can use AI. So this is what I submitted to the chatbot. I said, can you publish studies, give me the citations, talking about dissatisfaction. And I'm always very polite to my chat GPT, because I really believe that every time you say please and thank you to your chat GPT prompts, you're more likely to stay alive when the robots win. So very polite always. And this is what they did. They gave me all these citations. They gave me the top, things that lead to patient dissatisfaction. It just made my life so much easier, even for this talk. So then I was like, I wonder if I had made a presentation through Pop AI. So I did not, but I wanted to just show you this. This is another application, Pop AI. And I said, hi, can you create a PowerPoint, talk about the benefits? Let's assume the audience is unfamiliar. They want to incorporate these tools into clinical practice. After 2 minutes, they gave me this outline. I could have edited it. I chose a theme, and then this is what they gave me. So there's this lovely little title. There's this, again, this actually wasn't relevant to the focuses I had, but I think it's interesting talking about how we can improve diagnostic accuracy, how we can use data-driven treatment plans, predictive analytics, wearable technology, how we can assess surgical risks and benefits using AI. This I thought was very relevant to what I was talking about, how we can, help make patient communication understanding. I really like the fact that they said you can make it resonate with an individual preference, cultural backgrounds. I think it's just fascinating. So that generated in 2 minutes, and that could have been my talk. It's just I didn't do that, obviously. So, artificial intelligence, a lot of us tend to be like, oh, I don't know, I can't get into it. Well, I think it can actually really make your life a lot easier. However, there's also the risk. When you realize ChatGPT can do your job for you, then you start to, have an existential crisis. But regardless, I think it's a really worthy tool, worth exploring, spending a little time on, and seeing how it can make your life easier and, really help make the patient feel more comfortable. Thank you.
That's excellent. Actually, this is very exciting.
Thank
So
you.
my
Ajay, I've got a little comment to make here. This is Amit
Sure.
Chakravarti. Ravin, it's an excellent talk. Exactly. We are still learning on this. You guys have gotten it so easy. We used to walk uphill both ways to school. Okay. So anyway, what I'm trying to say is that we used to handwrite our notes,
yeah,
and then we used to learn how to type, and now you guys can do everything by AI. We used to, what you're doing, we used to do it the hard way. We used to videotape ourselves. And I had a little video clip which my nurse practitioner or my MA used to play for the patient. So that was hard because you had to do videos on everything. And now you just tell ChatGPT, hey, do it for me, and they do it for you. Huh.
And they do it. I'm sorry, I'm not referring your videos. I'm sure your videos are fantastic, but they do it really well. Maybe even better than I could
Believe
do,
me,
so
I know what my even my Facebook posts now sound so much better because I just click on help AI. AI help me, and now they feel that, oh my God, I write so well. So yeah,
interesting.
good.
I haven't thought of that application. That's my next one.
All right, great. We are learning. Nimesh, thank you for putting this together. Ajay, I know you are just like taking it off. We're back to the good old days, man. Come on, keep it up. Yeah, great involvement. Love it. Thank you. Keep it up, and I enjoyed being here. Thanks.
So the question I had, Ravin, was the surgical counseling part. So because it make me a little nervous to counsel a patient about your upcoming surgery, the benefits and risks that we discuss. Whenever sometimes patient used to say, can you tell me on the phone? I said, no, you have to come in person and do the face-to-face counseling, because I don't feel comfortable telling somebody about, this thing can happen, this is the surgery, this is what we're going to do. All that has to be done in person, in eye-to-eye contact. I don't know how you feel about this and the new technology, whether they can reproduce the same sort of a confidence between the patient and surgeon interaction for their surgical counseling part.
I think that's where, at least what I learned with this project, is those gaps, I found them hard. Like, I literally counsel that patient earlier very differently based on the length of their battery, for example, to be expected. So I think that's problematic. So I think you'd have to spend a little time engaging with your AI device, and you'd have to, measure and make sure, you have to do quality checks to make sure you agree with what they're saying. But I think once you invest a little time, I mean, it's a learning machine. And it should be good. I mean, like I said, it was 90% accurate. It was pretty good. Every patient was offered the chance to come back and ask me questions if anything was confusing. Surprisingly, like, barely anyone needed to or felt they needed to. So there's pitfalls. There's definitely going to be pitfalls and challenges. That is why I was using it as a supplement rather than the prime. I wasn't like, you have this diagnosis, chat with the AI. I was like, here's my summary of the diagnosis and the treatment. And now additional time can be spent, more time than I have, with the AI. And if you can refine it and tailor it to what you want, which you can, then I think it has a real potential.
Follow up to that, Ajay, is what I used to do is this video which was played during my time, and we can do the same thing with AI, is this is played before I get into the room. So in other words, you have the patient, they listen to it, so that your time, when you come and talk to the patient, you can still do face-to-face, but they'll have more knowledge of the thing. So the questions and what you have to tell them will be less. So that's, I think I'm still an old timer. I would still like to do the face-to-face, but this will help to tee the patient up for your talk.
Yeah, that's a great point too. Yeah, before instead of after. That's a great point.
Raveen, I have to tell you that we did a little study on vasectomy. We showed them the video and everything, and then we had a follow-up call. Can you believe only 50% of the people remembered what was told to them, in spite of doing everything? And
that's true.
It's amazing whether they're not listening, So I don't know. That is why I found to be very difficult. And if you're doing a major surgery, it is unbelievable how little they remember that what we told them, whether radical prostatectomy, especially with incontinence. I keep on repeating, that's number one. Number two is erectile dysfunction. They still don't remember. It's I don't know, maybe I'm in an area where education level is low, but this is what I found. And we did this very simple study. Do the vasectomy video, call them, and this is only on the same day. It's not yet 2 days pass by or anything.
I think you're right. I mean, the reality is, there's so much talk about this. So, like, how good is your surgical consent really? Like, how well can you really consent a person? So I think this is an opportunity to try to get closer to the best effort you can. But it absolutely can only be a supplement. It can't be a replacement. I hope we're not getting replaced one day, but
yeah, because the lawsuits are always informed consent, whether AI can let them sign on this, because many a time people are caught because, oh, you never got an informed consent. And we don't write everything when we go to the OR. See, it is just a very difficult, and I face this, all people ask me all these questions, how we can do. He says you have to mention and then just get them sign, and that is what you can do the best.
Yeah. Sorry, I'm going to let them continue because I'm hogging up time, but we can definitely talk more during the question and answer panel. Thank you, everyone, for your interest and enthusiasm. And thank you to the IAUA.
I mean, the only a follow-up on that, Harbhajan, is that if there's a lawsuit, they'll ask what are the things which were presented to the patient. You may have to actually submit that little AI section,
yes, right,
whatever you discuss with them.
Yeah, very important, because that saves a lot of time.
All right. Well, thanks, Dr. Sian. That was really an excellent excellent work that you've been doing, and I think we've had great discussion. We'll definitely have more opportunities at the panel discussion afterwards. Just in the interest of time, we would like to move on to the next speaker. We have Dr. Archana Kandekar, who's a clinical instructor at the Desai Sethi Urology Institute, also at the University of Miami, leading projects on computer vision and augmented reality, who today is going to discuss the use of AI technology in the OR.
Thank you. I hope you can hear me. Thank you, Dr. Sand, for that great talk and the great discussion. I think where we are going to start off is I'm going to just share with you what has been going on. First of all, I have no disclosures. This is just what has been going on over the last, say last 3 years. The investment, so far as, can you hear me?
Sorry, yes, okay, I see your screen now. I'm sorry, I didn't see it.
Okay. As you can see, the investment in AI has been growing exponentially. If you look at the last 3 years, the numbers have gone up exponentially. So have the publications. Just the publications that come up in the conferences, as well as the mature publications, you can see they have risen exponentially. If you look at the other side, just look at it. Every major society, every major journal, all the publications have been, everything that is there, it's AI.
Sorry to interrupt. I think your slides are not advancing, actually.
Can you see mine now?
No,
we're just seeing.
We're not seeing the presenter view. I think we did this in the beginning too.
Oh, 1 second. Can you see it now? Let me just share it again. Can you see it now? Not sure if you can.
No, we're just seeing...
No.
Let me just... Just let me know if you can.
Now we can see it.
Yes.
Yep.
Oh, okay, perfect. Yeah, so this was just about the investments in AI, and as you can see, right from Nature to ACS, everybody is talking only about one thing, that is AI today. So let's just see where the automation in robots came about. And the first robot that came about here was back in the 80s, where you had the Puma robot. Usually, the main thing that they looked at was neurosurgery, orthopedics. Gradually, you had a slew of robots come in, and then, from being in one OR somewhere in the country, now you have robots, multiple robots in every country, in every OR in the country as well as abroad. Now, let's just look at automation. Now, when we look at automation, this is a scale that was, published back in the early 2000s by Yang et al. And this is something that we still live by. If you look at the amount of autonomy that we have, pretty much even with the surgical robots coming in, it's still here. Like we have on the autonomy scale, we are pretty much level 0, level 1. Most of the work that is done gets replicated from what happens out. It's just a master-slave concept. There is no real thinking on the part of the robot. It's nowhere near what's happening in the other industries. You have Tesla coming in, you have electric cars, you have other modalities coming in that are going to level 4 and 5, but still not quite there. But, just things got interesting as late as last week. I don't know if you had a chance to look at this. This was something that came out of Dr. Singla's Institute, Hopkins. This is not done off the proprietary DaVinci, but it's done at what the DaVinci calls as a DVRK, which is a surgical research kit. They trained the DaVinci robot by installing multiple cameras on the robot itself to do surgery. I mean, not surgery, but do certain steps of the surgery on its own. And what they could see was that they could even replicate this, not just inside the OR, but also on other areas. Like this is just a mattress. They even tried it on porcine models, and you could see that this replicates on its own. Basically, you just press a button on it, and it just performs a concept. And here you can see things like knot tying that is getting done. Again, very early, very small concepts, but you can see that this is getting done. Now, why is this the correct time for AI integration? Now, we finally have enough computing power in computers just about everywhere to handle this amount of data. You have high resolution imaging, you have pixel quality of everything that minimal invasive surgery, the robots captured, of a quality that you can actually look at and you can run programs on. And also to exchange all these data, now you have integration speeds with 5G, even with wired connection, the optic fibers that are fast enough to look at this data and actually process this in real time. Of course, we are nowhere close to what we see in the science fiction versions. We are not going to have robots operate on us. But the challenge is how to slowly figure out this gap and come together. Now, AI, when we talk about AI, most of the times it's chatbots, it's fancy robots, but more than that, it is about data. The new player, the new kid on the block are the operative videos. We always had EHR, we always had imaging, we had the patient-related outcome measures that we could capture. In the last decade, we started having device data, especially the kinematic data, which I'm sure Abhilash will talk about from the Da Vinci robot. But now what we have is we have operative videos that are of high pixel quality and something that can be worked about. Now, when we talk about all this, it's important to talk about the federal push. The American Medical Informatics Association was the first to push this. There was something called as a High-Tech Act that incentivized the use of EHR in hospitals, in health systems. There was also NIH that pushed in a huge amount of money for this. And then gradually, as you could see over the last 2 decades, you have the EHRs coming in a pretty much every health system. Now, when I just say EHR, it's not about just Epic, Cerner, or a health system. It's about an EHR that has standardized measures for exchanging data. What they call it currently is something called as the HL7 integration. Anyway, so this is a paper that I like to keep because this is the basis of everything that you see in the world today. Everything, ChatGPT, every LLM, every DALL-E. This was the original paper that now has 140,000 citations. It was done by 8 people at Google DeepMind, and it basically forms the basis of everything that you see. Every presentation today that you see on AI starts off with machine learning, something on deep learning. But what we are going to concentrate is a part of deep learning today is computer vision and the use of large language models. Now, this is just the basis of what we are doing at the University of Miami today. You have data coming in from the EHR. We have data coming in, all the surgeries that are captured on a device. They are de-identified. All the messaging from the EHR is de-identified, completely HIPAA compliant, and it is stored on the cloud at the University of Miami. You have all this data getting processed at a backend, which I'll show soon. And then you have structured reports and you have data coming out. So it's a basic integration of HL7, the health system, and computer vision. This is what the operating room looks like. This is, if you look at the right, I'm just clicking on, this was done actually just after the surgery. And you can see how multiple annotations have been done on the procedure itself. And you can actually go back and just click on something, and you can actually go back and look at that particular step that was done in the OR. Now, this is just the front end, and this has multiple applications that I'll be just walking you through. Even if you look at things like placement of hemostatic agent, you have the model that is now trained in enough times to actually go back and show you the exact step that was done during the surgery. Now, again, looking at the frameworks that are involved for all this, the backend. Now, this is very complicated for a medical person. But if you work with engineers, you can actually understand what a deep learning framework looks like. For us, particularly, we use the PyTorch model. It was something that was made by Facebook back in the day, almost at the end of the last decade. And we use something called as a video transformer network. I know it sounds very complicated, but to put it very simply, till now, the way data was analyzed was in sequence. Like you had A to Z and everything was analyzed A, B, C, D in that sequence. What a transformer does is, and this applies to not just for text, but for video and everything that involves LLMs, is that it looks at data holistically, and it can actually look at A as well as Z together and just understand which parts are important in a way that you can actually train it to look at those parts sequentially. I know it looks complicated, but I'll show you what we do with it. And eventually, when you train the model, this is how the computer looks at your screen and understands it. You train it enough times to understand this thing that you're looking at is the grasper. You annotate it sequentially and enough times, and this is how the computer will start reading it eventually. Now, just going back, how all of this can be useful and how we can look at all this. Now, this is an actual OR going back to the 1920s. Now, at that time, surgery was almost like a spectator sport. You had surgery that was analyzed and visualized by a bunch of spectators or by a bunch of physicians or residents in the OR, and everything was scrutinized, everything was looked at. Gradually, what happened is this started becoming, the OR started getting more and more privatized. And now today you have the issue over the last, say, 3 or 4 decades was getting anything out of the OR to scrutinize was difficult. But now with computer vision and everything coming out on an MIS screen, this completely changes. And this is, the reason I'm putting it is, this is a pioneering work that has been published by Dr. Hung over the last 3 or 4 years, actually starting from 2018, where most of the data that he initially used was kinematic data. Kinematic data was data coming out of the Da Vinci robot itself, and then he compared it to outcome data. Over the last 3 years, he has switched to looking at actual video data and then comparing it to what happens at the back end and looking at patient outcomes and then comparing that going back. This has also been done in a bunch of other specialties, and video-based evaluation is something that is getting looked at. Now, coming back to what we are doing, I'd just like to run you through a few of the projects that we are doing at the Desai Sethi Urology Institute. This was our first project that's already published. We looked at the accuracy of warm ischemia time measured by our software and validating it. Now, the whole purpose of this study was not looking at, we are not saying whether warm ischemia time actually prolongs the creatinine, whether it is harmful in the long run, whether it's harmful in the short run. What we are trying to do is validating a model in which computer vision can tell us exactly when the ischemia started. You can look at a clip, a bulldog getting applied on the artery, and that is exactly the time where the ischemia starts. I know it looks very trivial, but it's a start. And if you look at what we actually found from the op reports, what we actually mentioned in the op reports, and what came about from the platform, there was a big difference in what was written in the op notes and what actually happened, a difference of 2.5 minutes, while the platform actually had a difference of only 8 seconds. Now, I know this seems very trivial, but when the power of this is extrapolation. When you actually extrapolate this data, not just for a single institute, but for a much, much larger scale of an institute to different health systems together, with all the other data also coming in through HL7 integration automatically with absolutely no manual input, then this thing can be scaled very high. So the scale and extrapolation are the things that we are trying to look at. This is our second project. This project was when we looked at the discrepancies between op notes and actual procedures. We used NLP methods. Let me just show you this. This is an actual op note that you can see that is generated from an actual OR. And you could look at, this is what actually happened, whether you are seeing, say, a specific, say whether you are visualizing an obturator now or not. And then we are going back and actually comparing whether this was mentioned in the op note. Again, this is trivial if so far as, say, visualization of the op node is concerned, but something like a leak test done after a prostatectomy or a tumor missed during a TURBT, then it's fairly large. This is what we actually found. We looked at data that was either matched, missing, or discrepant, and we put forward the accuracy of all of them. Again, pretty high in the 90s, but we did observe quite a lot of data that was missed, that was actually done in the surgery and not mentioned in the op node. What we did with this analysis was we gave it a clinical significance ratio. We gave, again, this is arbitrary, but we gave this a clinical significance rating. And we did find that, there were a lot of clinically pretty significant findings that were not mentioned in the op notes. Again, this is obviously clinically relevant, but if you extrapolate this is a very small step. If you extrapolate this to a lot of other specialties, then, the implications in billing can be pretty huge. And, we are still looking at how we can fix this so far as coding is concerned, but pretty much in the nascent stages. This is an interesting project, and also it's like a QI project that we have looked at. It's that every patient that has a major surgery, a major robotic surgery, has CBC and CMP done pretty much routinely in the post-op. This does increase a lot of costs, causes a lot of discomfort. So we thought maybe we can go back and see if all of them do actually require this. So what we did was we formed our own indigenous AI algorithm that included specific steps such as region resection, the amount of bleeding that the AI spotted, the warm ischemia time. Basically, through unsupervised learning, we let the machine decide what were the steps. Again, this is a very preliminary finding, but we let it decide what were the things that it could look at, and it could decide whether those cases could be flagged or not. Now, so far as flagging these cases are concerned, through our own algorithm, we found that the sensitivity of this was in the 60s so far as creatinine was concerned, and for the hemoglobin drop, it was maybe in the high 40s. Again, not much, but when you extrapolate these findings and you aid this with more clinically important measures such as heart rate, post-op blood pressure, I think a new algorithm can take this a long way. Now let's talk about AR in surgery. This is something that we have borrowed from our colleagues in neurosurgery. The reason I'm showing you this is we are trying to follow and use something like this in the prostate biopsy space. If you look at this, we have the CT scan of the patient himself superimposed on the patient, and you can see they're trying to create a butthole. There is a pre-registration process that they did, and then they are putting the CT scan on the patient itself, and through AR, they are trying to make sure that they do a EVD in the right space. The reason I'm just putting this up is because we are trying to do the same thing in the prostate biopsy space, in the transperineal biopsy space, where we are using registration for the MRI. This is a T2 weighted image of the patient, an MRI. You can see this. This is a TP biopsy. We are trying to put this, the T2 weighted image on the patient himself. What we do is, followed by this, we have a registration process. You can see these markers. These markers are leveled off by similar findings that we already previously marked on the MRI itself. And this is a micro ultrasound device that we are using. And we have a machine learning algorithm through which we identify the prostate, and we identify the same spaces on the T2 weighted images. Again, this is in the very nascent stages. This is nowhere near standard of care, but this is something that we are trying at the moment. Through AR, it's not just the segmentation and the biopsy itself. This is the actual segmentation process, but we can also do much more simpler things. Like you can actually see the screen in your augmented reality space. There is no glare. It just makes it easier for you to do the actual biopsy. You can place it where you want in the OR. This is us seeing it in a space, and then you can just continue with your biopsy in that space. This is again us trying to set the markers there, and this is another patient on which we are trying to do it. This is another way we are trying the segmentation, where we actually mark out the spaces on the MRI, and then we try and make sure that we can mark out the same spaces again on the patient itself. And this is us marking the same spaces, trying to mark out the same spaces on the MRI itself. Again, in very nascent stages, but we do believe that this is a way of fusion biopsy that we could try and then match up with the conventional fusions, conventional proprietary softwares. But we do have issues with elastic deformation. It's nowhere near as compared to what we have been seeing with the conventional softwares, but we are trying. Okay. Now, when we look at challenges that this thing brings about, this is, again, the data for all of these projects is not high quality. It is single institutional. There is not much diversity in it, again, being of single institution, and it does not look at any black swan events that happen a lot with surgery. It does not have the adaptability because it is trained on, pretty straightforward surgeries, pretty straightforward procedures. So we do have serious doubts on how it looks at, say, outliers and black swan events and how they are actually integrated into the algorithm. It actually spoils it. The key eventually is collaboration, not just with other urologists, but with industry, with collaboration with other specialties, what they are doing and how they are doing it. Collection and protection of data, obviously. And again, it's just using old hypotheses and trying to build on them. There is no need to reinvent the wheel on this. Thank you. Thank you for your time.
Thank you, Archon. For the interest of time, I wanted to see if anyone had any quick questions, but we might move forward and then come back in the panel discussion. Okay.
Really excellent talk. Really excellent work. I think, why don't we move on to the next talk for the moment, since we are running a bit behind, but there will be some buffer in the panel that we can definitely talk some more.
So for our next talk, I wanted to introduce Eli Tobiana, who's the CEO of ScribeMD. Which is an innovative AI-powered medical scribe solution trusted by over 6,000 physicians and nurses across the U.S., from renowned institutions like the Mayo Clinic to independent direct primary care practices. And so, Eli, we'd love to hear your presentation.
All right, let me just share my screen really quick. All right. Oh, I apologize. I'm just gonna have to restart Zoom for some reason. Yeah, to share my screen, I have to restart it. I'll be right back.
No problem.
Hopefully now it will work. Okay. All right, can you see my screen?
Yes.
Yes.
All right, so really quickly, my name is Eli Tobiana. As you mentioned, I'm the CEO of a company called ScribeMD, and a little bit of personal story about myself. So I'm not a physician. I sold my previous business in 2022, and at the time, my wife was an OBGYN here in California. We just had our second kid, and she was kind of like really burned out. She was doing a OBGYN residency, which was really intense, and then I look at the data and I was like, it's kind of crazy that doctors are getting burnout in like massive numbers, especially female doctors. I remember last time I checked, 50% of female physicians are not working full time 10 years after becoming an attending, which was mind blowing to me. And I was literally like wondering what can we do to solve it. And so what I've done is I've literally shadowed physicians for a whole week, trying to figure out what actually do physicians do on a day-to-day basis. And even though I'm like the son and the husband of a physician, I was kind of shocked. This is not at all what I was expecting. And I was shocked by the amount of like non-doctoring physicians were doing. Like most of the time was spent doing administrative tasks. And so in 2022, we built ScribeMD. That's right around when ChatGPT came out and new technology came out and could help automate some of the tasks. So think of this presentation more as like a practical guide on how to use an AI medical scribe, more than like a formal presentation, and feel free to interrupt if something is not quite clear. But super quickly, what is an AI medical scribe and why you should use it? Essentially, an AI medical scribe listens to the conversation between you and your patient and use a large language model, so similar to ChatGPT, to summarize the conversation and put it into a SOAP note format. So it saves you a ton of time. We've run a study up to 2 hours a day per physician, so it's pretty massive. And also one of the most surprising results, so we run a study in the largest health system in South Africa. One of the most surprising and positive results that we found out with using an AI medical scribe is it led to better patient interaction. So the patient satisfaction was higher. And if you think about it, it kind of makes sense because we've all been to a physician where you walk into the room and the physician is just kind of like typing on the computer. They barely look at you. And it's just, as a patient, it doesn't make you feel great. The great thing about an AI medical scribe is literally you can put your phone or your computer on the side, look at the patient's eyes, talk to them, and it feels so much more human, like a much more human interaction. So on that, maybe I'll give you a quick live demonstration on how you can use ScribeMD, or you can use other AI medical scribe. But just before that, a quick disclaimer. I know we talked about AI, we talked about the use of ChatGPT. Like I'm gonna like say that on top of every mountain I can go up to every physician I can, as much as possible, especially with patient information. Do not use ChatGPT. So obviously in your day-to-day life, you're welcome to use it, but ChatGPT is pretty open about not being HIPAA compliant. They train on their user data, and they're also pretty open about that. So unless your hospital has like an enterprise contract with OpenAI or with another kind of like ChatGPT equivalent, I would recommend really not to use it, especially if you put patient information. One of the most kind of like counterintuitive thing about ChatGPT is like very often physicians don't realize that they're leaking patient information when they ask ChatGPT to like write an email. So if you say, hey, can you write a referral letter for this patient to this doctor, and then you copy and paste the patient notes, that has obviously a lot of like personal information for the patient. So definitely would recommend against that. On that, quick demonstration on how to use ScribeMD and yeah, how you can have AI write your notes. Okay, so that's ScribeMD, and essentially it works on anything that has a microphone. So you can run it. We have like an iPhone and Android application. We even have like a small like physical device that physicians can use. They essentially clip it onto their white coat, and it can record the conversation between you and the patient. All right, so let's say I have a patient walking in. First thing I'm going to do is I'm going to pick the microphone. So here I'm using my AirPods. I'm going to probably pick that. I can pick the language. So we support over 50 languages. I'm going to pick the templates. So you can build your own template, and I'm going to go more in details about exactly what that means and how you can make that like fit your voice and your style of writing notes. And yeah, here if I want, I can add patient details and patient consultation context. It's especially useful if you have a follow-up conversation with a patient, so you can copy and paste previous notes in there. And yeah, obviously we support telehealth mode. So if you're talking to a patient on telehealth, we don't only hear your voice, but we can also hear your patient's voice. So okay, it's a little uncanny. I'm gonna do a fake consultation, and I'm gonna be both the patient and the doctor. And I hope you don't mind the terrible acting skills, but we'll try to make it work. All right. So let's say today I'm seeing a patient. She's a 58-year-old woman, and she's complaining about an overactive bladder. All right, walking into the room. Hi, how are you doing today? Well, I'm doing pretty good, but yeah, I've been going to the restroom a lot recently. Oh, okay, I'm sorry to hear that. Like, how many times have you been going to the restroom? I don't know, like maybe like 10, 11 times every day. Okay, okay. How about at night? Do you wake up at night to go to the bathroom? Yeah, I wake up maybe like 3 or 4 times just to go to the bathroom. Okay. Do you have like any like leakage, or do you like have like urgency where you cannot really control when you have to go to the bathroom? Yeah, like maybe once or twice a day, I do have leakage. So it's pretty annoying. Are you under any medication? Have you had any surgery before? Not really. I haven't had any surgery, and no, I'm not taking any medication. Sometimes I'm taking some like Tylenol for headache, but really nothing. Okay. Do you drink a lot of coffee or irritant? Oh yeah, I do drink a lot of coffee. Maybe I drink like 7 or 8 cups a day. Oh yeah, okay, that's a lot. So let me just check your record here. So I see your blood pressure is normal, 128/78. Your heart rate is 72. Your temperature is 98.6 degrees. So okay, here's my recommendation. Maybe let's ease off on the caffeine a little bit and try to limit to 1 cup a day. Also, maybe try not to drink anything after 7 p.m. I'm gonna order a bladder scan for you. And also we're gonna do what we call a bladder diary. So you're gonna just document every time you have to go to the bathroom, and maybe document what you're drinking and what you're eating prior. Maybe that's something that's triggering that. Also, I'll give you a referral to like someone who can give you some pelvic floor exercises. So we work with a physical therapy down the road. So I'll give you a prescription there, and maybe we'll follow up in 6 weeks and we'll review your bladder diary. Okay, does that sound good? Oh yeah, thank you so much. Really appreciate it. All right, so as you can see, like I'm just gonna pause it. So the conversation was like fully transcribed, but you really don't have to look at your screen. You don't have to look at all the detail that are being transcribed. But when you're done with the conversation, you can resume. So you can add some details. Maybe you want to add the vitals, or you want to add like, I don't know, like some observation. Maybe you checked our belly and like you could find like a mass, or maybe you couldn't find a mass, so maybe you want to add that. And you're going to press generate note. And so you see in a few seconds, it actually does generate the note for you. So here, the chief complaint is an overactive bladder with urinary frequency, nocturia, and urge incontinence. So subjective is a 50-year-old female, so that's what I mentioned. She goes to the bathroom 10 to 11 times a day, 3 to 4 times at night. So we talked about. And I said that she admits drinking coffee 7 to 8 cups a day. We also recorded the vital signs here, 128/78, heart rate, temperature. So overactive bladder. So here is the plan, right? That's what we talked about. Reduce caffeine to 1 cup a day, avoid fluid after 7 p.m., order a bladder scan, instruct the patient to maintain a bladder diary, and referral to physical therapy. Here, two quick things I wanted to show you. The first one is here you can use like a ChatGPT type experience to ask the AI to do even more with this consultation. So you can say something like, can you write a referral letter to the physical therapist? His name is Mr. Smith. Okay, press enter. You see, it's going to write a referral letter. Maybe then I can follow up with the AI and I can say, make it shorter, and the name of the patient is Miss Doe. Same thing. So it's going to write the letter shorter, then I can copy and paste it into my EHR or whatever I use to communicate with the physical therapist. And another thing that I think is really interesting is, so you'll see a lot of like these tools that are popping up that are creating a note for you. One of the really interesting thing is every doctor has a different voice. Every doctor has a different style of writing notes. Like some people like bullet points, some people like to be very narrative. And a lot of doctors also like specific note based on a specific type of consultation. So just here for the sake of this exercise, I created a note template for overactive bladder. So I'll show you. Scribely comes built in with like a ton of note templates. But here, I created one. Yeah, here, overactive bladder. And here what I did is I told the AI, hey, I want to create a new section called something called the overactive bladder symptom score. And basically I explained to the AI, hey, what like symptom score takes like 5 inputs and what each of them means. So like urgency, how many time, do they have incontinence? And then it gives you a score based on that to know if your symptoms are severe or moderate or mild. So now I can go back into my visits here, and I'm going to create, I'm going to reopen it, and I'm going to regenerate it with the overactive bladder template that I created. So it's going to take a second. So you see in a few seconds, it created the note, and it added that. So overactive bladder symptom score, daytime frequency, nocturia score, urgency score, urgency incontinence score, total score, symptoms, severity are moderate. So yeah, that's pretty much it. The last thing so thank you for the opportunity to talk to you. Obviously, if you want to try ScribeMD, so we have a free subscription. You can test it out for free. And if you want to try like a pro account that gives you like more language and allows you to do more visits, you can use that code and you can use ScribeMD for free for a whole month. But yeah, that's pretty much it.
That was really awesome, Eli. Really excellent technology. I do have a question. So it's not uncommon where sometimes patient interviews can take multiple tangents, maybe a lot of irrelevant information that the patient may bring up that do sort of discuss, but may not necessarily be not need to be reflected in the actual documentation. Is there a way to maybe filter it so that really just the relevant stuff for the visit at hand is recorded in the notes?
You can do that, and the AI will automatically do it. But it's such a good question, because let's say you go to your doctor and you say, hey, I just came back from a trip to Hawaii. You talk about your vacation, and then you talk about your symptoms. The AI actually has to make a decision. Is this, like the trip to Hawaii, is it relevant to the medical note? So I tell the AI, I tell people all the time, like, we try to limit the number of decisions the AI has to make, because decisions need to be made by the physician. But at the end of the day, when you summarize a conversation, summarizing means you're making choices between what's relevant and what's not. So sometimes the AI will add the trip to Hawaii because it will think that it's relevant, and sometimes it won't. But hopefully, like, models are getting better and better, so they actually are getting pretty good at knowing, okay, is that relevant medical information?
So I have a question, this Dr. Chakrabarty. Following up on that question, the template which you showed us, so is there any way to integrate the template so that will keep the history part relevant, because anything which goes out of the template is automatically filtered out?
Well, I'm not sure I understand the question.
So you showed a urology template, like in urgency template, right? Overactive bladder template you showed us. So following up on Nirmish's question is that, the trip to Hawaii and stuff like that. So suppose we have the AI only document the template symptoms. In other words, it only documents whatever you have in the template. Urgency, how many times, blah, blah, blah. So that anything which is out of the template, it's filtered out. Is that something which is doable? I don't know whether.
Yeah, I mean, what we essentially tell the AI is we tell them, you are an AI medical scribe for Dr. XYZ, and here's a medical conversation, and summarize it. Like, for instance, most notes have like a chief complaint, and they have most templates are pretty loose in terms of their definition, meaning that they have a subjective section and an objective section. All those, you can add a lot of data in there, right? So usually if a patient comes and has multiple symptoms, multiple complaints, the AI will be pretty good at capturing all of them. Does that answer your question?
Yeah, I mean, it kind of, but I understand. Some people come to you not with one particular thing. For example, a person who comes with urgency may have hematuria or may have UTI. Yeah, so that would make it difficult. Again, I'm just I'm absolutely a novice at this, but the younger people may have better questions than I have. So, but one quick question before I go: you have this for all specialties, right? Or only urology? You have got all specialties covered?
We have all specialty covered. What we do, and the reason why we talk to a lot of urologists, is one, we create, you can create a urology specific templates. And also, as you notice, we use speech to text. And so we use urology, like we implemented urology terminology so that our speech to text can capture specific words properly for urologists. So I'll give you an example. Like I had a urologist calling us a few weeks ago because they were using Urolift. And most speech to text, when you say the word Eurolift, they think that you're talking about the European helicopter company, EURO Lift, which is a European company. And so we said, okay, it's a urologist, so train on the specific word. And when you hear the word Eurolift, it's more like UROLIFT.
Yeah.
So can I ask you this one question? So what happens to the different languages? The patient who doesn't speak English, and does it translate into other languages?
So we can listen to a conversation in over 50 languages. So you can have the conversation in essentially any language. I mean, we're based in California. A lot of our clients, probably like 20% of their visits are in Spanish. So you can have the note in a specific language, and the note will be written in English. And also we allow the other way around. So you can have let's say, like we work a lot with a Canadian hospitals. And so you can have the conversation in French, and the note is going to be written in English, or the conversation in English, and the note is going to be written in French. but it's not translating. It's just capturing whatever is coming in.
Excellent, excellent. So again, we'll have a little bit more time, hopefully, in the panel. We just have one last speaker. Thank you again, Eli, for your excellent talk. I'll pull up the agenda one last time here. So for our next speaker, we're very lucky here to welcome Abhilash Sarangi from Intuitive. Abhilash leads the product marketing for Intuitive's digital products portfolio within the Asia Pacific region. Before joining Intuitive, he held commercial leadership positions within the medical devices industry with Johnson & Johnson Medical Devices and with Rig Nanosystems, a startup company. Abhilash himself is a computer science engineer and holds an MBA from IIM Ahmedabad. He's joining us remotely today from his hometown in Bangalore, India. So thank you also. I know the time difference is probably one that you had to circumvent to join us today. So we really appreciate that. So without further ado, we're really looking forward to your talk to wrap up the talks for today's session on transforming surgical care through innovative data and digital solutions.
Thank you, Dr. Nirmish. Let me just get my screen up here. Are you able to see my screen?
Yep, looks great.
Awesome. Well, thank you. It's I know it's late here in India, but it's been a pleasure listening to all of the speakers who've come before me. It's just so exciting looking at all the possibilities of AI in all of the different facets of the clinical practice. And it's my honor to be with you all today and to bring us home looking at some of the topics that have been touched upon by some of our earlier speakers. Dr. Archon covered it quite well in some of his talks. I'm going to build on that by looking at how we can bring AI and digital solutions into the field of surgery. So you all know the world of healthcare and surgery is changing at a breakneck speed. And it's truly coming into the operating room as well, right? The change is constant. And surgeons such as yourself must prepare differently, both in order to bring these technologies into the OR, but also to consider the human element of it, right? How do you develop teams that are able to fundamentally reshape the way they deliver care, the way they enhance patient outcomes, the way they ensure the long-term success of your practice? And that's where we believe that with the right knowledge and with the right training, hospitals across the world can leverage robotics, data, and digital to enable significant transformations and enhance performance and efficiencies like never before. So our journey at Intuitive has been quite interesting as well. In just a decade since our inception, in 2011, we reached a significant milestone. We reached a milestone of 1 million patients globally impacted positively with robotic surgery with the Da Vinci robotic system. And this came through relentless innovation and close collaboration with early adopters, particularly in the urology specialty. But this was just the beginning of the digital transformation of surgery. Fast forward to about today, and we've now impacted over 14 million patients in more than 70 countries with over 60,000 surgeons globally trained on our platform. But if we look forward and look at the next 10 years, we have a real opportunity to impact over 50 million patients globally. But it's not just about reaching 50 million people. We also want to see how can we help elevate surgical standards and expand access to higher quality of care across these 50 million procedures. And that is where we believe that to continue to have this impact at scale, you're not going just a robot is not going to be enough. You're all going to need a digitally enabled ecosystem around that robot. And that's where we believe at Intuitive that the next big leap is going to come. So in this presentation, what I'll do is I'll introduce you to a concept called surgical data science and how we at Intuitive are using it to transform healthcare journeys for predictable and favorable clinical outcomes. So we've seen today that there's a lot of excitement regarding digital transformation, technologies like AI, machine learning within healthcare. At Intuitive, we are laser focused on kind of looking at all of this holistically and together. So robotics, data, digital, how can we look at it cohesively? And that's a capability that is unique to robotic surgery in some sense, because robotic surgery fundamentally is computerized surgery. You have a computer in between the surgeon and the patient, and that allows us to capture data, the kind of which is simply not possible with just handheld open surgery or with laparoscopic endoscopic surgery. And right from the beginning, robotic surgery is built on digital foundations, whether it's cutting edge software, whether it's deep data integration, or whether it's just all-round connectivity. So when we kind of look around us at allied industries, right, finance, aviation, even professional sports, these industries have made a lot of progress, and they've reached a high stage of maturity in leveraging data to inform day-to-day decisions. But in healthcare, this maturity has been a little slower. But this is changing, and the potential here is enormous. By harnessing high-quality data from robotic systems and using that data to make decisions right when those decisions need to be made, we believe that the quality of care and the quality of surgery can really be improved significantly. So let's dive in and see what we mean here by surgical data science. So our key goal with surgical data science is to make high quality surgery reproducible in the hands of many surgeons. And that is what matters. The way we hit those 50 million, the way we reach those 50 million patients with high quality outcomes is if we are able to bring a number of surgeons, and we have 60,000 today, maybe another several thousand of surgeons, to as high a level of skill as we can. And that is really the goal here with surgical data science. How can we reduce variability in surgical performance? And how can we achieve consistency in outcomes, regardless of which country the surgery is performed in, which facility the surgery is performed in, or who's performing the procedure? Historically, almost all surgical quality work has focused on the patient or on the disease factors. Is the patient obese? Do they have a stage 4 versus a stage 1 cancer? Or basic surgeon and institutional factors, such as how experienced is the surgeon? Is the surgery performed in a high volume center? With robotic assisted surgery, we have an ability to go much deeper into the operation, and with new kinds of data that we can use to better assess what makes good surgery. However, one thing to remember is data by itself isn't very useful. And we can relate to that in our personal lives as well, right? Data surrounds us everywhere. It can be quite overwhelming, and we don't know how to make sense of this data. So true value is driven when we are able to derive actionable insights out of that data. So first, all of this data needs to be organized into analyzable data sets. And then deep analytics is performed on that data. And here's where technologies like artificial intelligence, machine learning play a role, but with an objective to deliver timely, relevant, and meaningful insights to the surgeons right when they need it. We refer to the cycle of data leading to insights, leading to action as a virtuous loop, and its impact can be exponential over time. So what are we trying to achieve with surgical data science? So in talking with surgeon collaborators like yourself across the globe, what we've heard repeatedly is an ask for a better, more objective way of measuring competence and proficiency in surgery. This could be for self-improvement, it could be for teaching. Now, that combined with an increasing body of evidence that shows that technical skills of a surgeon are strongly correlated with the patient outcomes in their surgery has led our R&D teams to dive in and understand how data-backed objective feedback can improve surgeon skill and thereby patient outcomes. So the result of this effort is a product solution called Case Insights, which launched earlier this year on our latest 5th generation DaVinci 5 platform. It is currently available commercially in the US, and we are bringing this solution to the Asia Pacific region in the next couple of months. So over the rest of this presentation, I'll give you a brief introduction to what the solution is all about and how it can benefit surgeons and patients. So Case Insights is an AI-based platform that provides post-operative review of surgical video along with objective measures of performance, what we call OPIs or objective performance indicators. It helps surgeons to quantify their skill levels and to then see how they can elevate their surgical skills with the goal of reducing variability in their surgical performance from one patient to the next, and thereby be able to consistently deliver high quality and safe surgery. How Case Insights works is by capturing a unique combination of data sets, which is only possible with robotic-assisted surgery. Video data, or what the surgeon sees during the procedure. System events data, or what the surgeon does during the procedure. So think of things like stapler fires, clip fires, fluorescence activations, instrument exchanges, endoscope exchanges. All of those are captured as events data. And then finally, this third pillar of kinematic data, which is how the surgeon moves during the procedure. So instrument path, instrument angles, economy of motion, kind of things like that. Combining these three data sets and analyzing them can expose unique insights about how surgery is performed. Let's look at a visual example here. So the DaVinci system, along with another one of our product solutions called the Intuitive Hub, has the ability to capture highly detailed information about how the surgeon moves during a procedure in addition to the video. So what you see here is a sync between a particular step of the procedure video, and on the right, you can see a kinematic plot path of each of the instruments and the endoscope and how it's moving. And these two data sets are synchronized to then be analyzed together. This kind of insight may not be possible with just video, right? It is only made possible by a combination of these data sets, which is uniquely possible only with robotic-assisted surgery. So what can you get out of all of this? So starting on the left, first, the video data which is captured. Through advanced AI and machine learning models, we are able to segment these videos into procedure agnostic phases, things like exposure, dissection, transection, which are common across different procedures, and then procedure specific steps. Like in a colorectal procedure, it could be splenic flexure mobilization or the anastomosis, things like that. And an analysis of the system events and the kinematic data can surface these OPIs, or objective performance indicators. Things like energy usage, clutching, economy of motion, force applied to tissue, and so forth. Helpful analogy here I found is to think of these OPIs as activity rings on an Apple Watch for surgeons. So just like the Apple Watch sets daily goals on movement, on exercise, on standing, OPIs can similarly set performance goals for surgeon to achieve optimal efficiency, precision, safety during robotic surgeries. You can now begin to see some of these similarities. So think of when you do a specific workout, The Apple Watch can give you detailed stats like heart rate, calories burned. Similarly, OPIs can provide detailed metrics to a surgeon about how smoothly they are operating the arms, or how smoothly are the instrument tips moving, how precisely are they applying force to tissues during the procedure. Another example, after a run, like your Apple Watch can break down the performance for each mile, the time taken, the speed, the heart rate, things like that. Case Insights also is able to break down the procedure into phases and steps and give you those OPIs for each of those phases and steps. So letting surgeons analyze their performance at each critical moment. And finally, the way the watch is able to track your performance over time, show you the progress and improvement, and also show you how you compare with a set of friends or some peers. OPIs have the ability to do that as well, where they can help you track your performance improvement over time and benchmark your performance against a segment of peers. So we like to kind of use this analogy as OPIs acting like a personalized fitness tracker for surgeons, providing clear, actionable data and insights to enhance their surgical workouts. The result is a kind of understanding of surgical performance that has honestly not been possible so far for surgeons. So right now, a surgeon can pull up their surgical performance on an app on their phone, on the My Intuitive app, just like they would be able to pull up their fitness data on an app on their phone. I'm just going to play this video here. So within an hour of completing the procedure, the surgeon is able to see their video here broken down into phases, steps, force applied to tissue, and so forth, and what instruments have been used. And they can see their OPIs on the right. These are quantified objective measures of performance, which are compared against their historical performance as well as that of their peers. So you might be wondering, yeah, all of this is great, but what does it truly mean? Why should we care about this? There have been over 50 papers published to date. One of the previous speakers mentioned a study by Dr. Andrew Hung. This was a study in 2016 where Dr. Hung and his team looked at two cohorts of surgeons, experienced and inexperienced surgeons, and looked at their kinematic data for 4 steps of a radical prostatectomy. The plot path here clearly shows that the inexperienced surgeons had movements of the instruments that were less precise and more gross than the experienced surgeons, basically indicating a difference in surgical skill. And there is a growing body of evidence that shows that that difference in surgical skill has a direct impact on clinical outcomes. Here's another study also by Dr. Hung, where the same 2 cohorts of surgeons were looked at, but this time there was a clinical outcome that was considered, which is return to urinary continence at the 3 and 6 month period. As expected, the experienced surgeons had a faster rate of return to urinary continence. But here the researchers went a step further. They looked at which OPIs were most strongly correlated with this improved clinical outcome. And they found 2 key skills here: usage of third arm and wrist articulation as the 2 key skills that were most strongly correlated with this better clinical outcome. So you can now begin to imagine the possibilities of insights like this with either self-improvement or with surgical training, right? Where if there's a fellow who's in your team and who's learning to do this procedure, the level of specificity with which you're now able to provide guidance and instruction to that person, to that fellow, to practice specific skills on a virtual reality simulator, to build that mind-muscle connection and come back into the OR with mastery over those basic skills. So that's really how Case Insights works. Data that's captured through the Da Vinci and Intuitive Hub gets analyzed and converted into insights, which are accessible to the surgeon on Case Insights and MyIntuitive, which then lead to action on the simulator, on a virtual reality environment to build those skills. So data leading to insights, leading to action. So once again, in summary, our vision with a solution like Case Insights and with surgical data science overall is to help reduce variability in skills, accelerate learning curves, and thereby seek to standardize great surgical outcomes globally. I'd like to end with this well-known African proverb. If you want to go fast, go alone. If you want to go far, go together. I think realizing this vision is going to be a challenging journey, and it's going to require close collaboration with all of you, all of our surgeons. Together, we can make this exciting vision come to life. Thank you. And I'll be happy to take any questions.
Thank you, Abhilash. We actually have a question from the audience asking how far are we from autonomous robotic platforms?
That's a great question. I think we're quite far from autonomous platforms. Like one of the previous speakers presented, I think there are a few levels from where we are to where we need to go. It might start with small steps, automating small steps, and then kind of moving towards more complex steps of the procedure, and eventually towards the entire. I mean, it's a far off future, is what I'd say right now.
You're saying we still have a job.
Yep. For a long time, I think surgeons are still going to have a job.
I think we can kind of open it up to the whole panel. So if anyone has questions for any of our speakers, except Dr. Kavusi, who had to step out, we can kind of take those questions, and feel free. I think we're a small enough group that we can come off mute to ask questions.
Well, it's not, it's not a question, it's a comment. It's amazing, mind-blowing, just kind of awed by what you guys have put up. And I wish we could, I will kind of perhaps take this to our national RP webinar in maybe January, if that's okay with you guys. So I'll talk to you, Nirmish, later on about that. But amazing job, guys, amazing. Applaud you.
On a lighter note, Amit, are you telling you are a senior guy?
Yeah. I mean, my heart is young.
No, this is excellent.
Thank you.
New technology. This is a very timely topic actually to discuss.
So maybe I'll pose a question to the panel, and maybe this is a bit more of a general question, but certainly as we've seen from today's talks, there are it's very multifaceted where AI can fit in, from surgical counseling to applications in the operating room, integration with the robotics, and the list goes on. For those of us who maybe are not as in tune with how rapidly AI is progressing, and now with multiple platforms to choose from, maybe ChatGPT is one of the more common ones that are out there, but as Eli mentioned, maybe there are other ones that are much better. It would be maybe it would be good to hear from the panelists. I know we're left with maybe like 5 minutes, but maybe what are your thoughts for how to even get your foot in the door for those of us who are pretty much novices at understanding AI and how to integrate with it in our practices? What advice would you give to urologists, let's say, who are trying to figure out how to best move forward with integrating AI in some capacity?
I think mine's probably the easiest to answer. Just explore, some of these things I was just Googling and exploring AI tools, things that resonated, just things to try. I mean, what I'm talking about is a much smaller scale than measuring surgical accuracy and techniques. So the simple way of making your life easier Even if you go into Google now and you just write something, like you say, how can I, what's an AI robot that I can use to help me generate or a standardized response to a patient who has a UTI symptom and I want them to go to the clinic to drop off urine and start an empiric antibiotic. And then it'll send you probably to ChatGPT in that specific example. But whatever the question is, AI is already doing it for you in Google. So just ask your question in Google and then find the tool. Again, I'm talking about things on a lower scale. I'll let Archon, of course, answer when it's a larger scale, like in the OR.
Yeah, I think that's great for the clinic. But when we are talking about the OR, I do feel that at the earliest stages, you do feel the need to collaborate either with industry or somebody on the academic side from the computer science labs. Because a lot of the things that, initially when you're building on things like you need, first of all, the ability to at least code just a bit, just understand how these platforms work. From that, you obviously can have somebody from the computer science team or somebody from industry process your things for you. But collecting all your data, processing it, keeping an eye on it consistently, I mean, consistently is the word, and then updating you yourself with how your colleagues from computer science are helping you, I think it's the way to go. But doing this alone as a lone neurologist, especially in the OR, it's a pretty uphill task. I don't think that's, at least at the moment, very achievable.
Yeah, I totally agree. And just one more point on that is, so I guess the use of the AI, that are literally two things you can do today. And if you look at the conversation we had today, there were two different patterns. One is like really kind of research and how can you automate the surgical process and make it better. And on the other end, you had all the administrative tasks. I can tell you already, most of your admin tasks, AI can do for you. The best way to think about it is AI is probably at like an undergrad level. So anything that you're doing today where you're like, I think like a 20-year-old who went to college can probably do that pretty easily. You don't need to go through medical school and through residency and fellowship to do that. Most likely AI can do it. So that's my recommendation.
So for our generation, so we don't really have to go to a class or learn some tutorials or take some teaching classes or something. You can learn on your own.
For sure you can. And by the way, Notebook LM, great tool. Totally agree with that. If you upload something that you want to learn about, just upload the document on it, generate a podcast and listen to it for 20 minutes. You'll become a pretty expert at it. Yeah.
And I mean,
that's easy learning.
Just one thing that I thought I would add on what Abhilash added through his presentation or on case insights. I do believe that for most of the AI platforms, for them to learn by themselves, I do believe that a lot of the things that they actually learn from is from data collection. And outcome data is extremely important. This is where most of the companies would not really help us, like industry would not help us, the computer science people will not help us. But what we need is like post-op clinic, basic data collection, like things like scales, like IAAF scales, like SHIM scores for patients coming in for our prostates, how their post-op creatinines. Obviously, the data that comes up from the system, from the EHRs, can be integrated easily now. But still, there are so many patient-related outcomes that come from the patients themselves, and it's still extremely important for us to document that. And that is where all these models, whether it's Case Insights or some other third party doing their work, you'd still need to provide them with all these data for them to actually improve and give you feedback. So that stays like all your talks with the patients in the clinics, they do stay just as important even today.
Yeah, Dr. Anchal, I cannot agree more. I think that's been one of our priorities as well. Is of course Case Insights is a tool that can help with analysis of surgical technique and surgical skill, but it's how do you close the loop with looking at clinical outcomes and then tie those back with surgical skills, and that's where the body of evidence today is growing fast, but it's still quite small. And our effort is in the US certainly, but also as we're bringing Case Insights into the Asia Pacific region, is to start looking at kind of local bodies of evidence. And as we start building up that body of evidence across different different countries, different surgical techniques, different patient anatomies, that's when there would probably be a more holistic picture that would emerge about how these outcomes are tied back to skills and to surgical performance.
Wonderful.
Well, the way I look at it, it's very helpful in learning for the trainees, for residents, medical students, and fellows. It was a little tough in our time, how you train a resident and, or a fellow or medical student. I think the education, it will change the education part as well as research. It's going to change that part too. It's very now easy to train. They can watch these AI generated models and learn quickly than doing it by hand. Okay, do this way. You're watching, you're supervising the resident, how he's operating. It was a little challenging in the past.
Yeah, and Dr. Singla, I fully agree. And just one point to add there, I know we're on time, is just being able to look at objective data, right? Then now the feedback is no longer subjective; it's objective. So we found even the conversations that a senior surgeon would have with a learning surgeon become that much more specific and that much more kind of non-controversial, because the feedback has become very objective now. You're not kind of relying on subjectivity, which could get challenged.
Terrific. Well, I think we are just past the top of the hour. Again, I just really want to thank all of our speakers for such an engaging session, and thank you all also all of the registrants and attendees for taking time on a Sunday to join us on this session. I think I definitely learned a lot, and I hope you likewise also found something helpful here. We'll make this recording from today's session available on the IAUA website, so that way it'll be accessible if you ever want to refer back to it. And with the speaker's permission, perhaps we can also even make their contacts available for those who are in attendance. If that's desired, you can feel free to reach out to either Dr. Sheth or myself, and we can try to coordinate accordingly. But on that, I want to thank you again all for joining, and enjoy the rest of your weekend.
Well, we want to thank the organizers actually also, both Nimish and Kunj did a great job. Actually, I think it was a very timely, very good topic that everybody was really interested in learning how things are changing so fast in today's world of medicine. So no, really thank you for organizing such an excellent course, excellent webinar.
I second that. Thank you.
All right. Thank you, guys. Enjoy your Sunday.
Thank you, guys. Very good. Very good. Thank you.
Thank you, Kunj.